Hello, I'm Kevin Fernando, a GP working near Edinburgh in Scotland and content advisor for Medscape Global and UK. Welcome to our podcast, Medical Mentor, a bite-sized regular chat for all of us working in primary care. Podcasts will cover hot topics, practice pearls and hacks, as well as pitfalls to avoid, helping make our lives a little bit easier in primary care, but ultimately to help improve the lives of our patients. In this podcast, I'm going to talk about the diagnosis and management of gout in primary care. So let's start with a typical case we might all see in primary care. Henry is a 58-year-old man working in marketing. He presents to us in duty surgery with a very sore and red left big toe. He's never had this before. Past medical history includes hypertension, and he's never smoked. He admits, though, he enjoys alcohol liberally and regularly, particularly his craft ales. Current medications are lisinopril 20 milligrams once a day and bendroflumethiazide 2.5 milligrams once a day, which he also admits he takes only sporadically for his hypertension. Bloods done at his previous hypertension review demonstrated normal kidney function. On examination, blood pressure was 154 over 92 millimeters of mercury, and there was clear evidence of gout affecting his right first metatarsophalangeal joint, or MTP joint. So, Henry's case raises a number of questions for us in primary care. Firstly, how do we manage Henry's symptoms of acute gout? Secondly, what lifestyle advice should we offer Henry to prevent future gout flares? And do we need to review his medications? Next, when do we offer Henry urate-lowering therapy, and what are our available options? Next, if we do treat Henry with urate-lowering therapy, what target serum uric acid level should we aim for? And finally, does Henry require long-term follow-up of his gout? So let's answer these questions. Firstly, though, gout is increasing in prevalence, incidence, and severity, yet remains under-recognized and under-managed by both healthcare professionals and also patients. It's actually the most common cause of inflammatory arthritis globally. Now, gout commonly affects the first MTP joint or base of the big toe, as is the case with Henry. But gout can also affect the midfoot, ankle, knee, hand, wrist, and elbow. Now, hyperuricemia is the most important risk factor for gout and leads to deposition of monosodium urate crystals in various tissues and joints, leading to inflammation and subsequent destruction. Any medical condition that causes high cell turnover, such as psoriasis, myeloproliferative disorders, also lead to increased serum urate levels. Now, urate is partially undertaken by the kidney, so any impairment in kidney function also increases serum uric acid levels. Overall, a change of thinking is required for gout, a shift away from a troublesome, largely self-inflicted recurrent condition due to lifestyle to a common chronic inflammatory arthritis that can lead to joint destruction, long-term pain, and disability. Recently updated United Kingdom NICE guidance on the diagnosis and management of gout reinforced this shift, and I'll be drawing on key take-home messages from this guideline throughout this podcast. Additionally, cardiovascular disease is the major cause of increased mortality in patients with gout. So cardiovascular risk assessment and mitigation of cardiovascular risk factors should also be a key focus of management, alongside treatment of acute symptoms and consideration of urate-lowering therapy to prevent gout flares. So first question then, what do we offer Henry for his acute attack of gout? Well, firstly, gout is a clinical diagnosis. We need to exclude septic arthritis and other forms of crystal arthritis, such as pseudogout, which involves deposition of calcium pyrophosphate crystals predominantly in the wrist and knee. Serum uric acid levels often fall during an acute attack of gout, so has limited diagnostic value. If the diagnosis is uncertain, we should consider joint aspiration and microscopy, looking for crystals. Acute attacks of gout should be treated promptly. We should advise rest, ice, and elevation, and pharmacological treatment of gout should be guided by comorbidities, current therapies, kidney function, and patient preference. Now, UK NICE guidance suggests first-line therapy should be either a non-steroidal anti-inflammatory drug with or without PPI cover, or colchicine, or a short course of oral steroids. If using colchicine, I usually prescribe 500 micrograms twice a day for 3 to 5 days as tolerated. Usual side effects limiting use of colchicine are abdominal pain, diarrhea, and nausea and vomiting. If eGFR is less than 50 mils per minute, colchicine should be used with caution at a lower dose. If using steroids for gout, I usually prescribe prednisolone, 30 milligrams once a day for 3 to 5 days. Intra-articular or intramuscular steroids can also be considered if non-steroidal anti-inflammatory drugs and colchicine are contraindicated, not tolerated, or ineffective. So next question then, what lifestyle advice should we offer Henry? And do we need to review his medication? All patients with gout should be given verbal and written information about their gout. The Versus Arthritis charity in the UK produced an excellent patient information booklet on all aspects of gout. Lifestyle interventions to discuss include weight management and reducing intake of high purine foods such as red meat, game such as venison, offal such as liver and kidney, seafood, particularly shellfish, oily fish, and Marmite and Vegemite. Interestingly, vitamin C, cherries and cherry extract, and low-fat dairy products have all been shown to reduce serum uric acid levels, and intake should be encouraged where possible. Now, with regards to alcohol, of course, excessive alcohol intake should be avoided, but it's actually particularly beers and spirits that increase the risk of gout, rather than traditionally red wines and port. We should also remind Henry to maintain adequate hydration, around 2 to 2.5 litres of clear fluids daily, not including tea, coffee, or alcohol. So, do we need to review Henry's medications to reduce his risk of a future flare-up of his gout? Well, actually, diuretics, particularly thiazide diuretics, such as Henry's benroflumethiazide, are indeed associated with increased serum uric acid levels. Switching his benroflumethiazide to an alternative class of antihypertensive agent would be beneficial to him. Interestingly, losartan and calcium channel blockers, such as amlodipine, are better options as they have uricless uric properties and may actually help reduce serum uric acid levels. If individuals are on low-dose aspirin for secondary prevention of cardiovascular disease, this can be continued as the benefits outweigh the risk in terms of reduced uric acid excretion. So next, when do we offer Henry urate-lowering therapy and what are our available options? There's growing consensus that urate-lowering therapy should be discussed and offered to all patients with gout at the time of diagnosis, and not just to those with recurrent flares, very high serum uric acid levels, gouty tophi, kidney impairment, or those with gout at a younger age. There is, however, no strong evidence to support the use of urate-lowering therapy in people with asymptomatic hyperuricemia. Overall, though, there persists poor uptake of urate-lowering therapy by healthcare professionals and patients. Only 1/3 of people living with gout receive urate-lowering therapy, and only 1/3 of these individuals use it effectively. A move to a treat-to-target principle is strongly advocated in many gout guidelines globally, including the UK guidance. Lifestyle modification shouldn't be the prime focus of the management of gout. Pharmacological modification with urate-lowering therapy should also be given equal priority. The UK NICE guidance advocates offering urate-lowering therapy using a treat-to-target strategy to people with gout at their first or subsequent flare who have either multiple or troublesome flares, CKD stages G3 to G5, so that's an eGFR below 60 mils per minute, to those who are on diuretic therapy, to those who have evidence of gouty tophi, or those who have evidence of chronic gouty arthritis. Now, urate-lowering therapy is best delayed until the acute inflammation and pain has settled. We should usually wait at least 2 to 4 weeks after the acute flare and then check serum uric acid levels. If individuals are experiencing more frequent flares, urate-lowering therapy can be started during a flare. And importantly, we should not stop established urate-lowering therapy during any acute gout attacks. UK NICE guidance suggests offering allopurinol or febuxostat first line as urate-lowering therapy, taking into account comorbidities and preferences. Allopurinol should be first line in people with gout and cardiovascular disease, and I'll come on to this just shortly. When prescribing allopurinol, it should be initiated at 100 milligrams daily and can be increased at 4 weekly intervals up to 900 milligrams daily in divided doses. However, if eGFR is less than 60 mils per minute, the dose should be capped at 100 milligrams daily. In contrast, febuxostat is safe in kidney impairment and is initiated at 80 milligrams once a day and can be increased to 120 milligrams once daily after 2 to 4 weeks if serum uric acid levels are still above target. Of note, in patients with pre-existing major cardiovascular diseases, so for example, a myocardial infarction or a stroke, febuxostat therapy should be used cautiously due to past conflicting cardiovascular safety evidence for febuxostat. Now, when initiating urate-lowering therapy, individuals should be offered prophylaxis for up to 6 months to prevent an acute flare-up of their gout. We can offer either colchicine, 500 micrograms once daily or twice daily, or a low-dose non-steroidal anti-inflammatory drug with PPI cover, or a low-dose steroid. Again, if colchicine and non-steroidal anti-inflammatory drugs are not tolerated or contraindicated. So once we've started Henry on urate-lowering therapy, what target serum uric acid levels should we aim for? Once again, a treat-to-target approach is strongly advocated in all global gout guidelines. The UK NICE guidance recommends treating to a serum uric acid target of less than 360 micromoles per litre to prevent further crystal formation and to dissolve existing crystals. However, we should consider a lower target of less than 300 micromoles per litre if individuals have evidence of gouty tophi or chronic gouty arthritis, or if individuals continue to suffer frequent flares of their gout despite a serum uric acid level of less than 360 micromoles per litre. And finally, does Henry require long-term follow-up of his gout? Guidelines are quite clear. Urate-lowering therapy should be considered as a long-term treatment for Henry, and UK NICE guidance recommends at least annual assessment of his serum uric acid levels. Additionally, at each annual assessment, lifestyle modification can be reinforced, as we've already discussed. And also the opportunity can be taken to reassess Henry's cardiovascular risk factors and offer him advice and try and manage any significant risk factors as appropriate. So thank you all for listening. I hope you found this podcast helpful. Please do listen to our future Medical Mentor podcast, which will be available on all major platforms. Follow me on X, formerly Twitter, at Dr. Kevin Fernando, or email me on kfernando@webmd.net if you have any questions, comments, or ideas for future podcasts. Thank you again for listening.